All to the 96th session of the Weekly Huddle. I'm your host Anoop Agrawal, and joining me today is my friend and co-host Praneeth Palamari. We both are cardiologists working at Care Hospital, Banjara Hills. The format of the Weekly Huddle is known to most of you guys who are attending today's session. The idea here is to bring the common clinical topics for discussion, things which we otherwise take it for granted, but for which we don't have very clear-cut answers. Sometimes these common clinical scenarios, they make us uncomfortable in making decisions. We still do make clinical decisions based upon our own expertise, but more so being more pragmatic, taking more practical factors into account. With this platform, we typically try to address those scenarios and try to discuss what is the best case that we can come forward in these situations. I have just dropped the case for today on the WhatsApp group, so if you are online, you can browse it, and I will also read it out, the case for today. And since we are talking about headache, we also have a headache expert with us. We will take her opinion as well once we hear what my cardiology and medicine colleagues have to say. I chose the topic of headache because this is as common of a topic as one can get. I don't think that there is any subspecialty or general practice where we don't get patients of headache. And I will say to myself that I'm not very good at history taking for headache. I can take very good history for chest pain and try to differentiate about what are the clinical syndromes associated with chest pain, but I'm not very good at taking history for headache. So hopefully we will learn something today with this regard as well. When I present the historical aspect of today's case, I won't be able to tell you more about the features of it, again because I don't know what to ask. And that is again something which I will seek opinion from my colleagues and experts for today's discussion. So the case for today is a 56-year-old female. She was admitted around 2 months back. At that time, she presented to my clinic with classical signs of progressive angina, which was recent in onset. Her ECG and echocardiogram was normal, but because of her clear angina history, I subjected her for angiogram, and her angiogram suggested a prox LAD stenosis, which was stented. The problem was that she also has diffuse distal LAD stenosis, and she also had diffuse disease in her distal RCA territory. Because those vessels were quite distal and they were diffuse, they were left alone in terms of invasive management, and we opted for medical management for those lesions. She did not have any other residual major epicardial stenosis at that point of time. The event was without any complication, and she was discharged after 48 hours. But because we knew that there is a lot of diffuse disease, we did want to manage her angina with optimal medical management. And at that time, she was discharged on all the routine medications that you would expect, along with nitrates and Nicorendil. And she was also on her routine old medications. Mostly relevant for today's talk is diabetic medication, for which she had been taking for about 7-8 years now, and her diabetes seems to be reasonably controlled. Her comorbidities included hypertension, which is of the similar duration as diabetes. Other than that, she does not have any other comorbidities. So she actually presented during the first follow-up, that was about a month of angioplasty, and at that time she complained of headache. And she said that she used to have headache previously as well. This is not new to her, but recently it has progressed. And she thinks it could be because of the newer medications that she had been. Mind you that she was not taking a lot of these medications before her angioplasty, so a lot of these medicines were new to her. Because she was on nitrates and because she was on Nicorendil, I thought that maybe her headache is precipitated because of the two drugs. So last time I stopped her nitrates and her Nicorendil, I added trimetazidine and I increased her beta blocker. So that was during first follow-up. Now this is her second follow-up. This is 2 months after her index angioplasty. She comes now to the clinic. She says that her angina is slightly better. She is able to walk around and do her work without any major problem. She does not have any rest symptoms. But she just cannot get rid of this headache. This headache comes maybe once or twice a week, and she ends up taking sometimes paracetamol, sometimes she takes a combination with Ultracet. I have told her to refrain from taking any NSAIDs and that she is complying. She is not taking any NSAIDs. She used to take occasional NSAIDs before angioplasty. So now she's here with me. Cardiac syndrome seems to be stabilized a little bit, but this periodic nagging headache is there, which comes once or twice a week. I thought that would be completely obliterated by stopping nitrates and Nicorendil, but that did not happen. And at this point of time, I'm thinking whether I should just observe her headache, or whether I should do some diagnostics, or whether I should send her to an expert for headache evaluation. As I said, I did not poke too much into the history of headache because I personally don't think that I'm well equipped for that. I did screen for some of the early red flag signs, which I didn't find any, and that we can discuss what those red flag signs are. But all in all, otherwise she was doing fine. Her current medications are aspirin 75 milligrams daily, clopidogrel 75 milligrams daily, atorvastatin 80 milligrams daily. Her metoprolol is 50 milligrams once a day. Telmisartan she is taking 40 milligrams, cilnidipine 10 milligrams twice daily. Trimetazidine long-acting combination of long-acting preparation of 35 milligrams twice daily. She is on oral hypoglycemics, which does include an SGLT2 inhibitor, and she is on some multivitamin and pantoprazole and all this. So these are her overall medication regimen. So I will start the discussion now. Praneeth, the floor is yours. If this patient was to come to you with a headache, what would you do? And the points that I'm trying to highlight for discussion today is, if the patient do get headache with nitrates or Nicorendil, what are the strategies that we can use to improve drug tolerance? And is there a way by which we can actually differentiate whether this headache is because of the drug or whether the headache is because of something else? Because these drugs are very important. We are trying to control our angina, and I don't want to just stop a medication because I think that could be the cause of headache, where the headache may actually be because of something else like a tension headache or a migraine or whatnot. What are the basic diagnostics that we as cardiologists or general physicians are expected to do for the headache management? Do each one of them need a CT to evaluate for neoplasm or whatnot? And what are the red flags where we should be referring these patients to a headache specialist or a neurologist? So Praneeth, the floor is yours, and after that I will ask opinion from my other colleagues.
Right. So a commonly faced situation of headache, but as a cardiologist, that symptom is something which does not ring a bell or does not sound like something of importance. Now, you already said on nitrates. So first thing that I look at is whether there are any drugs which can produce headache, most commonly being nitrates, which have already been stopped. Your question of how do we test it? I don't think there is any other investigation where we can test whether nitrates are the reason for headache. It's only a trial and error that you stop and see for the response. If headache still continues, then probably it's not the nitrate and there is something else going on. Now, having said that, with the presence of headache because of nitrate, and then if you have to give nitrate to control angina, how do we do it? Probably changing the formula to certain extent in the form of changing dinitrate to trinitrate or mononitrate, and probably changing the timing, something like from morning to something like afternoon, some here and there, no proper signs I believe, but some tweaking here and there, and trying to reassure and get the confidence of probably managing headache to a certain extent, unless it is not bothering, because this is something which will make them have a better quality of life in relieving angina. Now, when evaluating headache, most important thing which I look into it is the common causes related to head and neck. Most important thing, I also do not personally stay much focus on where it is. Yes, I do ask where exactly it is to get some idea, but probably evaluating headaches as per locations and site less likely. A few CNS symptoms in the form of any visual disturbances or any vomiting, etc., to try to get sense of any signs and symptoms of raised ICT and any neurological deficits to kind of grossly look whether there is any intracranial pathology. Not there. Most thing I would look into is visual disturbances. I'll ask them about their vision and ask for an ophthalmology consultation to get their vision checked. Second, ENT related issues, any symptoms of earache, discharge, etc. is what I ask. Sinus related issues, probably sometimes they do check for sinus tenderness, etc. Dental issues in the form of any caries tooth, I ask them, and probably if they complain of anything, suggest them a dental checkup. Then most commonly is a cervical spondylosis, which is commonly associated with headache. So do ask them for headache in relation to neck pain and etc. Equally suggest them to do some physiotherapy. Head and neck issues, going beyond head and neck issues, one thing as a cardiac issue, something that I look into is obstructive sleep apnea syndrome. We'll try to look into whether that is causing any headache, and probably uncontrolled hypertension, which probably less likely because this patient is on one, and maybe rarely as a hypoglycemia, because as a cardiologist, again, we tend to be more aggressive in managing diabetes as a risk factor reduction. Maybe she is having occasional hypoglycemia causing headache. And lastly, being summer, could be dehydration, one of the reasons which can also produce headache. So I would try to kind of educate the patient on so many issues, and whatever quick fixes which we can do in terms of physiotherapy, ophthalmology checkup, avoiding hydration, checking sugars, etc. I would try to initially at least get the confidence and get away with the first consultation. But if headache is constant and if it is continuously bothering her, probably then I would refer this case to a neurologist for evaluation, because persisting headache is something which will be an important symptom. I think I answered all the questions. Anu, if there's anything else, I would clarify.
Praneeth, have you ever ordered CT scan for headache evaluation?
No, I would refer them to neurologist, and I'll handle neurologist to take it rather than ordering myself.
Okay, all right. Thank you for setting the stage, Praneeth. We will continue our discussion. I will ask my cardiology colleagues first if they have anything to add. If I may invite Dr. Vijay sir, Dr. Vijay Reddy sir, if you can hear me, could you please unmute yourself and share your thoughts? And Praneeth, I will tell you the things that you have mentioned. The OSA part, I think that part is pretty clear. Early morning headache, we are all used to asking our patients if the headache is restricted to early morning. In this particular case, it was not, but this is a very strong sign to say that we may be dealing with a sleep apnea. Uncontrolled hypertension was not the case in this patient. So at least those two things I can take out of the discussion. Then others, everything else that you have mentioned, like cervical spondylosis and all these other things, those are all on the table. So Vijay sir, if this patient was to come to you, what would be your approach in this particular case?
Good evening, everybody. Here, in the index case, I don't think it is the headache is because of the nitrates. For the simple reason, the nitrate headache, the main feature is once you stop the drug, automatically the headache will disappear. Here in this patient, the headache is not absent even after the discontinuation of the nitrate. So it is. The second thing is patient is receiving cilnidipine, which is a calcium channel blocker. It can also cause some headache. Third thing is hypertension itself can cause headache, especially occipital headache. And the rare possibility is patient after angioplasty, he must be on DAPT. So some intracranial bleed may cause, that is of course, it is a rare possibility because patient will have mental status, all those things, they are very obvious. Lastly, hello?
Yes, sir. Yes, sir. Please go ahead.
Lastly, the most important thing is in this any headache, patients, they will have some amount of stress. So stress headache is most likely cause, and it requires detailed history. Thank you.
Thank you so much, sir. Any cardiology colleague of mine in this audience who wants to share his thought or her thought, you can please unmute yourself or put your question in the chat box. And while you gather your thought, may I ask Shankar sir for his opinion? Shankar sir, I'm sure you have probably managed, if not, I would say probably thousands of headaches. How do you handle these kind of patients? Cardiac patient who comes in with non-specific headache, or what can you teach us in terms of what kind of history we should be taking? Shankar sir.
Good evening to all. First, I will speak of this nitrate tolerance. The nitrates are notorious for tolerance, tachyphylaxis. So, to avoid that, as it is discussed now, we give eccentric dosage schedule, one in the morning and 7 hours or 8 hours apart, and another dose, and we keep nitrate-free interval in the night, so that the nitrate tolerance will be very less. And the second thing is, apart from this eccentric schedule of dosage, then we can add some antioxidants. This is ample evidence of literature in the literature there. N-acetylcysteine, because these nitrates are very essential in ongoing angina. So definitely we should give the essence of it. And at the same time, if we add N-acetylcysteine, we can reduce the nitrate tolerance. And L-arginine is also proved that it is a substrate for the nitric oxide synthesis. So vitamin E, vitamin C, folic acid, and especially if it is combined with the carvedilol, it is both alpha and beta blocker. So the nitrate tolerance will be less. And especially in heart failure, where we combine isolazine, that is hydrolazine, and the isosorbate dinitrate, there this hydrolazine, though it's a vasodilator, but it reduces the nitrate tolerance somehow. So these antioxidants and these agents can be used along with the nitrates. And there is one more product, it is yet to come into the market, that is a pentaerythritol tetranitrate. It is the dosage is 80 milligram twice daily. I don't know whether it has come into the market, although it is. So it is, there is no nitrate tolerance with this molecule. So eccentric schedule of the dosage, and pentaerythritol tetranitrate adding antioxidants and carvedilol or hydrolazine to reduce the nitrate tolerance. And coming to the headache problem, the nitrates are notorious for a headache also. If there is no headache, that means the nitrates are not at all working. So headache is a common side effect of the nitrates. See, the headaches of headache with the nitrates is of 3 types. So one is the nitrate headache, which comes immediately after usage of this sublingual or buccal spray or oral nitrate. That comes, that lasts for 20 to 60 minutes. And initially it will be there, but after the continuous usage, this will be abated within 1 to 2 weeks. That is the nitrate headache. And second headache, what we see that comes a little delay after several hours after the usage of nitrates, is migraine. This migraine, usually it is seen in the migraineurs, and they were in individuals with the family history of migraine, they are susceptible to migraine attacks with the nitrate usage. So where the patient will have a unilateral, bilateral throbbing headache, and preceded by the visual aura. Then photophobia will be there, and there will be history of nausea and vomiting. These are 5 symptoms will be there. If amongst the 5 symptoms, 3 symptoms are there with the headache, then we should think of migraine. This is according to the international headache guidelines, the recommendation. And third one is another headache we see along with the nitrates, which is triggered by them. That is the cluster headache. The cluster headache, it is it's a very severe and unbearable pain. Actually, the patient will have suicidal ideation. It will be this cluster headache will be triggered by the nitrates, alcohol, and the strong odors, aroma, and exercise, warm climate or hot summer. And it is strictly unilateral. Unlike migraine, which may be unilateral, bilateral, but this is strictly unilateral and strictly side locked. And the same side that pain will come every time. So it will be orbital, supraorbital, temporal, or combination of these sides. And the duration is important. Depending on the duration, there are sub-classification of this TAC, that is trigeminal autonomic cephalalgia. So it will be lasting for 15 minutes to 3 hours. So unilateral, side lock, and lasts for 15 to 3 hours, and it comes in clusters. Sometimes these clusters may last for weeks to months. So with the cluster period, with the cluster free period will be there. So remission. So this is a cluster headache. This has to be thought of when the patient is on nitrates. So apart from this, if the persistent headache is there in the primary headaches, what we have discussed so far, migraine, the cluster headache, and apart from that, the chronic tension type of headache, that also should be kept in mind when the patient has got a headache. When the patient is on usage of nitrates. And the last word about the red flag signs. So when the patient has got a sudden onset of severe headache, that is the worst type of headache in his lifetime. That is a thunderclap headache. So that has to be, especially we come across in subarachnoid hemorrhage. And if the headache has got a worsening pattern, most of the times it will be seen in the mass lesions. And if the patient has got a fever, neck stiffness, and any cutaneous rash, we should think of meningitis or encephalitis or meningoencephalitis. So if the patient has got any focal neurological signs or symptoms, then we should be careful regarding further evaluation. If the patient has got a headache associated with the papilledema, definitely it is a red flag sign. And any headache, if it is aggravated or triggered by cough, exertion, or Valsalva maneuver, if the headache is accentuated, then we should be very careful. We should go for neuroimaging. Then, especially in during pregnancy or peripartum period or postpartum period, the patient complains of headache, then we should think of some cortical vein thrombosis. So these are we go by this history to look for the red flag signs. If the red flag signs are there, then we should investigate with the neuroimaging, and wherever necessary, we go for a lumbar puncture and other chemical tests. So this is my, so here the patient has got persistent headache, and so we should take a detailed history, whether it is migraine or cluster headache or a chronic tension type headache. If there are no red flag signs in this case, we don't need any further neuroimaging or lumbar puncture others. But in my clinical practice, most of the times, 90% of the times, patient fits into these primary headaches only, where migraine, cluster headache, and chronic tension type headache or combination of these primary headaches will be there. If the red flag signs are there, we should go for further investigation. Thank you, one and all.
Thank you, Shankar sir. I'll invite Dr. Rukmini for her comments. Dr. Rukmini is a neurologist who had been in our huddle before. Ma'am, my question to you, other than the index case that we are talking about, is if you could just two things. First of all, as a cardiologist or as a general physician, what is the bare minimum that we should know or we should talk to our patients about headache? Because I'm pretty sure even neurologists wouldn't want us sending pretty much every single headache to their clinic, because then it will just be a waste of the resources. So what is the bare minimum that you think cardiologists and other specialists should know about headaches, so that at least we can differentiate what is alarming and what is not? Few of them are quite obvious, like what thunderclap headache that Shankar sir mentioned, or if somebody comes with headache and one side is not working, or if there is hemiparesis or hemiplegia, then we know that there is a major problem there, or there is a visual disturbance or whatnot, then we know there is a major problem. But barring those pretty obvious syndromes, what would be things that we should be looking at, particularly with regard to drug side effects? When can we say that this headache is likely because of nitrates or Nicorendil, or when this headache is not because of that? And then what would you tell us to look for the signs where you can come into play, and what kind of value do you add when these patients come to you? So Rukmini ma'am, next few minutes, the floor is yours.
Thank you. Actually, I think most of the issues that you've asked about has been covered by you, Dr. Praneeth, and Dr. Shankar very well. So, it makes it easier. So the only thing about drug-induced headache is that if you have a vasodilator, you expect a headache. You expect a mild headache to moderate headache. And as Dr. Shankar had said, that if you think the patient is on nitrates or vasodilators, the headache actually is an indication that the drug is working. There are a couple of trials also, like there's a trial which was done in patients with stroke, ENOS trial, and there's PROPHES trial, which was done with dipyridamole. ENOS was done with GTN. So where they looked at whether the nitrate-induced headache or the dipyridamole-induced headache actually resulted in a better prognosis for the patients. And surprisingly, or maybe not surprisingly, it did. Not all the factors, but it definitely reduced the mortality at, I think, 30 days or a longer period, or 3 months period. So these are the who were on these vasodilators. How would you? So most of the things that I know about drug-induced headaches is that normally they respond fairly well to NSAIDs, acetaminophen, even paracetamol. They respond well, and the headache tends to reduce in intensity as the days go by. So I think that's one of the major things that you should know. Like if you have a drug-induced headache, the only thing that you know about a drug-induced headache is that the patient did not have headache before and started to have headache after you started a medication which is known to cause headaches, like vasodilators or nitrates or like calcium channel blockers. So if you wait for the headache to come down, the severity will come down. The red flags, as has been described well before, has been that if you have an early morning headache, if the headache is occipital-nuchal region, the patient is feeling there's a drop in alertness, the drop in sensorium. Even if the patient is feeling a little dull, and the headache is very severe, it's the worst kind of headache that is happening. If the headache is continuous, most of these headaches that happen with drugs are not continuous. They have a waxing and waning effect. I think as did your primary patient also, like she was having intermittent headaches. Again, intermittent headaches suggest that it is not it's probably a primary headache. So the thing is that, so if you have a continuous headache and you have the worst headache, then it is better to evaluate and assess. There's no harm in over assessing. A lot of times you do, you can have combinations. You have to have a detailed history. A lot of patients don't talk about the headaches, most of them would have had a headache in the past, but they probably do not think about it till they have this major event. And so they attribute everything to this event. But if you ask them a little more in detail, they probably would have told you that the headaches were there from probably 2-3 years back. It was not coming so frequently. Now the frequency has increased. So that all helps you in identifying a primary headache. So if you have unilateral throbbing type of headache associated with photophobia, phonophobia, response to, lasts for 3 to 4 hours, then you know that you're dealing with a migraine. Again, it would have worsened. And a lot of events are stressful. So if you have a chronic tension type headache, the headaches usually are better when you sleep. So once they get up free of headache. And by the time it's 10 o'clock or 11 o'clock, they start developing headache. And it's a holocranial, non-throbbing, dull, aching headache which persists till the evening. Again, response to sleep, and then once they sleep and get up, they're better. So that is a chronic tension type headache. As Dr. Shankar had said, cluster headaches or the trigeminal autonomic cephalgias, they all have unilateral persistent headaches. They have a lot of autonomic symptoms, like they can have redness in the eye, watering from the eye, stuffiness of the nose. So if you have these symptoms, then you know that you're dealing with trigeminal autonomic cephalgias. They come in clusters, cluster headache or paroxysmal hemicranias. So these have, they again, some of them respond to indomethacin or oxygen. So then you can look at these aspects and check it out. So, if you ask me, like, if you ask people about headaches, they will keep telling you about headaches. So I don't think that, like, I'm sure every one of us have had a headache in our, in our past. And I'm sure when we've had our headaches, some of us must have had very severe headaches at some point or other. The only reason we know that it is not something, dangerous is that we know that it lasts for a while and it responds, and then we've not had the headache again. So I think if you have persistent headache and it is very severe, I think you need to evaluate, irrespective of what the modality is. Thank you.
Thank you, ma'am. I have a few questions for you, and then I request if anybody in the audience has got any questions or comments, particularly question for Rukmini madam, you can either put it in the chat box or you can unmute yourself. So, ma'am, question is, and this is a very common scenario that cardiologist gets. We put a drug therapy for heart, either in the form of anti-anginal or in the form of person who had recent MI or whatnot, and they develop headache. Now, we have an option of stopping the medicine, but we are giving these medicines for a purpose. So the question is there a way out where we can continue these medicines and also treat the headache, or you think that is like creating a problem and then trying to resolve the problem? It is always best to stop the medicine and see how the headache responds. What is the best course of action in these scenarios?
No, I think, the first option is only correct. So if you're having a patient who requires a medication in terms of his cardiac status, you have to give the medicine and then treat the headache. I don't think that you need to stop unless it's very severe and you think you cannot manage without stopping the medication, which is like, so you have to give at least a period of a month or 2 months for the headache to come down. You can add on acetaminophen symptomatic therapies during the initial period and wait for it to come down. Most of the nitrate-induced headaches do come down as the time goes by.
And when you talk about treating headache with drugs, of course, in these patients, we don't like to give them NSAIDs. But other than paracetamol, is there something that cardiologists can give without any concern for these therapies? Like we typically hate to write headache treatment anything other than paracetamol and tramadol. But what is your take on it?
I think paracetamol is a good drug. I still think that you can give NSAIDs intermittently without worrying if you're not, if the headache is intermittent. So again, you need to take a detailed history of the headache, whether it is continuous, throbbing, is it lasting for 3-4 hours, is it happening throughout the day, worsening in the afternoon, because both, so one, it could be a drug-induced headache, and as Dr. Shankar has very nicely pointed out, it could be a worsening of migraine. It could be the onset of a tension type headache. Obviously, the stress is there. So you need to assess which of the three and then decide on what treatment to give. So if you have a tension type headache, an anxiolytic would really help, like say adding an amitriptyline or an escitalopram would probably help in them. If you have a migraine, if you're already on a beta blocker, actually increasing the dose of the beta blocker or just keeping the beta blocker on along with Civilium or Cinnarizine or something like that can help. And you can see most of the neurologists also prefer only acetaminophen as the first therapy for headaches. Only if you have a cluster headache or a paroxysmal hemicrania, indomethacin is supposed to work well. So my advice would be you take a history, see whether the headache is only after the starting of the medication. If you think it's only after the medicine is started, then you can just give them acetaminophen, say paracetamol, tell them that you can take the paracetamol whenever you have the headache, keep a headache diary. Let us have a review back after some time, and then you give them a month's time and then see again whether the headache frequency is coming down. If it is coming down, I think you can continue.
The next question is, ma'am, whenever we talk about drug-induced headache or whatever, like cardiac drugs and all those, can drugs actually precipitate other kind of headaches? Like, let's say if a person has tension type headache or a cluster type headache where the frequency is not that much, and now I add a calcium channel blocker or I add a potassium antagonist like your Nicorendil and whatnot. Are those drugs, can those drugs precipitate an existing pathology like a cluster or a tension, or these drug-induced drug-induced headaches are totally separate from the existing headache disorders? What is your thought on that?
Migraine is the commonest cause of a primary headache, and any vasodilator can increase the frequency of migraine. It can increase the frequency of cluster type headache. They don't normally, tension type headaches are usually not precipitated by these drugs. So, so migraine, yes, definitely yes. Cluster also occasionally. Cluster is a rarer group of headaches. Patient would have had a history of headaches before it. Migraine, they may not actually talk about it.
And ma'am, last question that I have for you is, when we give beta blockers as a treatment for headache, do you have a data about cardioselective beta blocker versus non-cardioselective beta blocker? Because we know that patients who do not have cardiac problem, propranolol becomes the commonest prescribed medications for headache treatment. But a lot of cardiac patients, they are on cardioselective like a metoprolol or a carvedilol or something. Is there a sound reason that we should switch them back to propranolol, or you think we can continue the same?
So you can continue on cardioselective beta blocker. So the thing is that if most of our patients, I would actually prefer to start on a drug like topiramate, which is safe for most cardiac patients, and it's equally effective for migraine instead of starting on propranolol. Somehow the propranolol has, we somehow use propranolol for non-cardiac patients as in cardiac patients. Probably that's our scare also. I think probably I should ask you also whether it's okay to give propranolol for a patient who might have a anginal episode.
Right, no, because we have seen propranolol being used very commonly in a lot of pathologies outside of heart. In fact, cardiologists don't use propranolol as much as other specialties, particularly gastro and neurology and whatnot. And many of the times, we tend to just continue provided it is given for a very specific purpose. The problem that happens is that when young people are put on beta blockers for a long period of time, now they get beta blocker induced issues. But the question that comes to us is that when these patients who are on, let's say, carvedilol, and if they continue to have headache, then is there a good rhyme or reason to actually switch carvedilol to propranolol, thinking that they will get the beta blocker effect at the same time? They may get better benefit with headache, and I don't know of any such data behind. What I do know is that gastro guys become very, very particular that if they are using propranolol for variceal prevention, then they like propranolol more than any other cardioselective beta blocker. But I don't know if there is some such thought process from the neuro standpoint or not.
Yeah, I mean, we also believe that probably propranolol has got a better response in headache, but see, in general, propranolol now has become the second line. So for us, it's okay not to give propranolol. So if the patient is already on a cardioselective beta blocker, we don't add propranolol. But if you ask me for a patient who comes in directly, I would start on propranolol. Whether giving them a propranolol would be better or not is a difficult point to answer. So I would rather prefer using something else altogether in a patient who's on a cardioselective beta blocker. So that's my point.
Right.
But actually, even cardioselective beta blockers are supposed to have effect on the migraine headaches. So that it is not the fact that they're cardioselective doesn't reduce their impact on the headache.
Ma'am, would topiramate drug work in headache treatment other than migraine scenario? Like, let's say if I want to continue Nicorendil and I think of adding topiramate to reduce headache burden, do you think that will help, or that's actually creating more trouble?
Topiramate is very useful as a migraine prophylaxis. So if you think the patient has got migraine, yes, topiramate is useful. If you don't think that the patient has migraine, see, that's again, I don't know. See, most of the times when we use a drug-induced headache, it normally does respond well. I mean, I've seen a lot of patients who have had, I have not seen nitrates, but I've seen it with dipyridamol, because we used to write dipyridamol a lot for recurrent strokes. And they also develop very severe headaches, but the headache comes down as the time goes by. So you don't really need to treat it with a prophylactic drug unless they have an underlying migraine. And I think the same thing holds good for nitrates also. So unless you think that there's a migraine which is being triggered off by the nitrate, then I think yes, topiramate is a good drug.
Right, and that dipyridamol, I think from the cardiologist standpoint, that's a history now. I don't think we are ever using dipyridamol these days.
Neither are we. Sorry, neither are we. We used to use
yeah.
it. This was during my residency period, and like, I think it was from 2008 when the trials had come in, because we had that match trial where clopidogrel was not supposed to be combined with aspirin. So we used to only combine aspirin with dipyridamol because we thought that it caused more bleeds. So that was that was fairly long period. I think till around 2016, we were using only that.
Yeah.
After that, we didn't find so much of evidence of bleed with clopidogrel and aspirin combination. It's gone back to that.
So back in the day, dipyridamol was used as an agent for cardiac stress test. And before that, it was being used as a sole antiplatelet agent for us. But I don't think ever in my training I used dipyridamol. I know during my training, neurologists used to use, but cardiologists never did. I believe in the cardiology spectrum, the drug lost its charm maybe more than a decade ago, or probably 1.5 decades ago. Dipyridamol related stress test was still done, but recently I don't think that is also happening right now. So if anybody has got any other questions or comments, anything they can add. And while we do that, I will invite Somaraju sir for his comments. And sir, I have a lot of questions for you, but I first want to hear your thoughts about today's discussion, and then I will ask few questions about your experience with headache. Somaraju sir.
Thank you, Anoop, and thank all of you. And most of the issues are already covered. So coming on to this patient, when you do an angioplasty and when you have a patient on dual antiplatelets, and particularly the newer dual antiplatelets, the chances of bleeding into the brain and subdural hematoma is particularly common. You have to have a lower threshold to investigate and ask for a CT relevant imaging. We should have a lower threshold. That's very important. Any change in the nature of symptom and which is not ascribed to the patient's original symptoms, any change, even a minor change, should make us investigate and have a lower threshold. Having said that, we should keep in mind that one of the commonest cause for subdural hematoma today is dual antiplatelets unnecessarily prolonged for a lot of cardiovascular patients, whether it is post-angioplasty or post-bypass surgery. Many of them, some of them are not on follow-up. Some of them, while on follow-up also, they are unnecessarily continued on dual antiplatelets. That is that's a wrong practice. And one of the commonest reasons why this should be avoided is we see increasing number of patients with subdural hematomas in patients who are aged. I just wanted to highlight that issue. And also keep in mind when you are dealing with patients who have headache, the history, to be able to take a good history in a patient with headache is fundamental for all practitioners, including cardiologists. You can't deny that. You can't say that it's not our specialty. And it is everybody's specialty, and we have to deal with it. If you have any questions, feel free. Thank you.
Sir, I have a lot of questions, so if you could just keep your mic unmuted for a few minutes. Sir, what is your tips and tricks about nitrates and headache? Like choosing a particular type of nitrate, or giving a particular time of the day, or combining it with something. What are the tips and tricks that you can share with us, sir?
As already pointed out, nitrate headache is generally temporary. It passes off after the first a few days or a week or 2 weeks, and then generally they tolerate it well after that. And also keep in mind that with today's armamentarium of anti-anginal medications, it's not essential that chronic angina pectoris, chronic and stable, do not require nitrates all the time. We have alternative medications. Many of you already pointed out. It's not essential that they should be, nitrates should be given. That is even applicable to even acute situation. We have alternative medications. The patient has severe headache, intolerable, and mind you, some of them have such a severe headache they even vomit. The moment you have headache with vomiting, you are quite concerned and want to investigate. But do wait, and it's not essential that patient who is so much intolerant to nitrates should somehow be given nitrates. It's not essential today with the existing other medications available.
Sir, my next question is, how frequently do you see Nicorendil and calcium channel blockers implicated as a cause of headache?
Calcium channel blockers unusual, except when you use short-acting say nifedipine, etc. And Nicorendil, yes, occasionally some patients have it, and sometimes you have to withdraw it because of the headache, but a very small percentage.
Sir, what is the role of giving high dose aspirin right before nitrate? Do you think that will help with headache, or you think we are inviting more trouble by giving high dose aspirin?
To treat headache of nitrates, high dose aspirin, in the absence of a specific indication for a cardiovascular disorder, the patient who is already older and is already on another antiplatelet, high dose aspirin, unless it is justifiable, you should not go for aspirin. You should give some other drug to treat the pain of headache of nitrates, not try to go for high dose aspirin.
And sir, in your opinion, is there any preparation of nitrate you think is tolerated better than the others, or they are all same?
To me, it varies. Sometimes patients vary, and you can try out. But I don't know of any specific nitrate which is better tolerated than others.
Perfect. Thank you so much, sir. Those were my questions to you. Shankar sir, you have something to add?
My heartfelt compliments to Dr. Rukmini. She has enlightened us, and for also enlightening on movement disorders in the recent Epicon at Jaipur. I couldn't meet her, but she presented very nicely the movement disorders in various diseases we come across. So my heartfelt compliments to Dr. Rukmini Kandadai. And second thing is, amongst this migraine or cluster headache, when we suspect we are tempted to give triptans as usual, but the cardiologists and the general physicians, they should know that they are contraindicated in coronary artery disease and stroke. So especially in acute coronary syndrome, chronic coronary syndrome, the chronic stable angina, that is vasospastic angina, and strokes also. These triptans, especially the sumatriptan, and even in the cluster headache also we give the intranasal zolmitriptan. It is available in the market now. So we are tempted to give, but especially this patient who is a case of coronary artery disease, here triptans are contraindicated. That one is to keep in mind. And this is okay. This I want to clarify that regarding the triptans.
Thank you, sir. Actually, and I think that's a very correct point that you have kept. I mean, triptans can cause vasospasm, so it should be avoided in any patient who has got a ischemic heart disease or a ischemic cerebrovascular disease. So we actually prefer to give only naproxen domperidone combination in such patients as a pain relief medication. Thank you, sir, for your kind words.
Thank you, Rukmini ma'am. Thank you, Shankar sir. Praneeth, your comments on today's discussion, anything that you want to add or modify?
A lot of points added, Anoop. I think the point of relevance to me at least is in relation to nitrates. Now that it's been more clear now that we need to know whether it is only related to drug and is there any associated symptoms like the associated migraine which got triggered by nitrate, which is a possibility. So probably spending some time in looking at the history of migraine is something is relevant, and maybe taking help of a neurologist to get a clarity is always useful. And basic rule of drug-induced headaches being stop the drug, it should get better, or maybe with the time probably patients will be tolerating it better and the headache should go. Persisting should always need evaluation, and it is okay to probably over investigate than leaving it aside, particularly if it is persisting. And usage of this one paracetamol for most of the time working well, and I think once in a while using short course of NSAID calculated risk is probably worth taking it. And the last word of cautious use of triptans, or particularly when we have to use. Thankfully, I don't see cardiologists not prescribing triptans. I think only it belongs to the prescription of a neurologist. So I believe they will look into it. But as a word of caution, whenever we give triptan, it is a responsibility to rule out ischemic heart disease or ischemic cerebral or any ischemia anywhere because of its vasospastic action. And I believe, as Somraju sir highlighted, most of the things will be clarified with history. And as the old saying goes, patient is actually telling the diagnosis. So I believe if we kind of train ourselves in taking good history, probably going back to basics in terms of good history taking and spending time with patient, probably most of these issues can be better diagnosed and resolved. So I think these are what I could get from today's session.
Thank you, Praneeth. I think that triptan thing is quite obvious. I don't think cardiologists across the board like triptans. And whenever I see anything in the prescription, I make sure that their coronary syndromes are either absolutely stable or they don't exist at all. Anything other than that, using triptans for long term, it can create trouble. So fortunately, we don't see that often in our prescription panel. There's no doubts about it. Shankar sir or Rukmini ma'am, I have a request for both of you. If you could please give us a little bit of reading material about headache, something that we as a cardiologist or physician should know. And if you could share that on the WhatsApp group so that all our group members can at least refresh their learning about headache and at least do the basic history taking and understand the basic aspects of headache so that they can manage a little bit better in their OPD, and also to understand when is the time to actually send them to a specialist like a headache specialist or a neurologist. So either one of you, if you could just share some reading material for us, that will be quite helpful.
Sure. I should do so.
If nobody has got any other comments, I would close this.
Dr. Anoop,
Yes, sir.
About headache, we make a textbook of medicine. Today, the headache chapter in Harrison new edition came. Just read the headache chapter, it's beautifully written. And also Goldman Cecil. And neurologists will also tell you more books. Lance Gould, there is a special textbook on headache. But it doesn't increase your abilities to make diagnosis. You have to deal with your patients and be involved, and that it is your responsibility first to take adequate history and evaluate, then only refer for additional help when needed. And also keep in mind, anything nocturnal, whether it is chest discomfort or headache, nocturnal has a serious consequences. And apart from sleep apnea, Dr. Praneeth pointed out, any nocturnal headache is a serious issue. Thank you. Keep in mind.
Sure, sir. Thank you so much for your comments and your suggestions and also your questions. I would close this session. We will meet next Wednesday with another topic. And most of you know that all the huddle sessions are recorded and they are available online. So you can browse through it and listen to it during your dead time. Any comments or suggestions or any topics to be included in the future, please let us know. We have a WhatsApp group where we continue our offline discussion after a particular session. So thank you all. Good night. I will see you all next Wednesday.
Thank you.